بسم الله الرحمن الرحيم. Every time we will show some pelvic interesting cases. So please concentrate to know what is the common in this scenario and what is the rare, and try to find differential diagnosis. Our first case, a pregnant female, 27 years old, and coming for ultrasound. And when she do ultrasound, we found these findings. This is the normal fetus here. And there is something here in the left adnexal region. Again, we have here the normal fetus. This is a fetus 8 weeks, so it's normal for these 8 weeks, a normal crown rump length, normal amniotic sac, and this is the amniotic sac, and this is the secondary yolk sac. And here this is a normal decidual reaction, so this is a normal intrauterine pregnancy. But when we came through the adnexal region, we found that there is a cystic lesion, complex, cystic and solid, with the cauliflower papillary projections within the cyst. So what could it be? And what we should do in this settings, you must put Doppler. And here is the Doppler of the case. So this solid parts, lobulated outline, they are vascular on color Doppler. So being there is solid and cystic component and there is vascularity, this means that we put it as a suspicious lesion, ORADS 4 or GYRADS 4 being suspicious. But what will it be with pregnancy? So first message, that the Doppler is a must in these cases to know that these solid parts are vascular or not. This is the 3D ultrasound. Does not add too much because in the 3D ultrasound we just found the solid parts causing this solid papillae projecting inside. In the early pregnancy, we must also do Doppler for the uterine artery, and this is the Doppler for the uterine artery, show normal monophasic wave with normal RI and PI in this case. So then we have to think. We have a suspicious adnexal mass with pregnancy. We put it ORADS 4. The patient was 8 weeks, so it's not worth to do MRI in that period because the baby is so small, and preferably not to do fetal MRI before 12 weeks. The first possibility that this mass is neoplastic. It is a complex lesion with solid part and vascular on color Doppler, and then the patient come again after 2 months for follow-up, and on follow-up, fortunately, we found that there is only minimal increase in size by millimeter. And so there is a good possibility that it is not a malignant lesion. So we put the patient into choice, either to wait and see again or to do MRI. She didn't do MRI and she came back for follow-up, and each time it's a stationary course. So this time we think about other rare entity that it may be so because there is no increase in size during pregnancy. We thought that it could be decidualized ovarian endometrioma with pregnancy. What is the decidualized ovarian endometrioma? It is a complex adnexal cystic lesion which may mimic ovarian malignancy. However, awareness of its occurrence and the specific imaging findings using the combination of both ultrasonography and MRI and prospective diagnosis may be possible to exclude this rare entity. And this is a paper for a decidualized ovarian endometrioma in a pregnant woman mimicking ovarian malignancy. And in this case, both magnetic resonance imaging and ultrasound was done. This was the ultrasound picture. It is solid and cystic, but here in this case, it is more solid than in our case. And this is the MRI. It shows bright signal in T1 and T2 with the presence of endometrioma, and this is the decidualized part of the endometrioma, which is a rare finding seen. So in this case, it was proved to be decidualized endometrioma. So upon searching in the literature and being the mass is not increasing in size, we put the possibility of both findings, that this lesion may be left complex ovarian mass with appearance mildly increase in size, so borderline ovarian tumor is to be considered versus it may be decidualized endometrioma for follow-up. And the patient didn't do MRI. I think if the patient did MRI, it will be better to characterize this lesion more. And then the patient was delivered by cesarean section, and left ovarian cystectomy was done, and the pathology revealed that it is borderline atypical proliferating papillary serous tumor with no cyst wall invasion, and now she's on follow-up after delivery in order, because in the borderline ovarian tumors we have to follow up the ovary and the other ovary also, because there is incidence of recurrence. So this case was borderline papillary serous tumor as we first described. But at the same time, you must know the entity of the decidualized endometrioma. Another case, she's female patient, 32 years, coming for abdominal discomfort, and she's pregnant, 13 weeks. Here is the fetus. Here is the fetus. Placenta anterior. Normal intrauterine. Fetus 13 weeks old. But there is something in the adnexal region. Here, this is the right adnexal region. And there is also large one on the left side. This is a large mass on the left side. Then we have bilateral solid adnexal masses in a pregnant female. When we do pelvic ultrasound, then you find there is fluid, there is mild ascites seen here. So you have to look on the upper abdomen. Here there is mild ascites, and here also we find something that worth diagnosis, that in the other ovary there is a follicle spared. There is a spared follicle sign. Then on going up, here this is the bilateral ovarian masses, solid with follicle sparing, and when we put Doppler, it is highly vascular on color Doppler with malignant circulation. This is malignant circulation, lack of arborization, arteriovenous shunting, large central vessels. This is malignant circulation. Then when we go up to the upper abdomen, this is the abdominal ultrasound. We found these lesions. We find here that the stomach is markedly thickened wall, forming what we always describe as the pseudo-kidney shaped sign. This is the air inside the lumen, and this is the diffusely thickened abdominal wall. And here we found also epigastric amalgamated lymph nodes seen in the epigastric region. So it gives us a strong clue that this patient might have lymphoma. And we recommend that the patient should take biopsy, either endoscopic biopsy from the stomach wall or biopsy from the epigastric lymph nodes via CT biopsy. And that was our report summarized as bilateral adnexal solid lobulated masses, likely ovarian, larger on the left side. They are highly vascular on color Doppler. The stomach shows circumferential wall thickening about 3 cm in thickness, while usually the normal stomach is about 3 millimeter in thickness, enlarged amalgamated epigastric lymph nodes. And then the conclusion is bilateral solid ovarian masses, likely malignant, associated with thickened stomach wall and epigastric lymph nodes, highly suggestive of lymphoma. And you must give a recommendation in your report. Biopsy from the stomach or epigastric node is recommended, and that was the biopsy. Gastric round cell infiltrate, lymphomatous for immunohistophenotyping, and duodenal. It was affecting the gastric and the duodenal, so this is a lymphoma. Unfortunately, the patient aborted thereafter, and they managed the case accordingly. We have another case. This is a full-term baby at 38 weeks, and the patient just coming with vaginal bleeding. And here, a large problem. There was bilateral adnexal, complex cellid and cystic multilocular, solid and cystic, and there is also a mass seen in the vagina. This is the cervix, and here there is a lobulated mass seen in the vagina, in the upper vaginal part, and we follow up the case. She delivered, of course, because she's 38 weeks, and the lung here in the fetal MR is well developed. So they delivered the case, and then on biopsy of this lesion, it was metastatic from the ovarian malignant lesion, and we published it as a case report in the British Journal of Radiology. This is the role of diffusion weighted image, because in this case also we cannot inject gadolinium in this case, so we depend on the diffusion weighted image in the assessment of ovarian carcinoma with vaginal metastasis accidentally detected during malignancy, during pregnancy. We have here another case. This is a fetus, and this is a large cystic adnexal lesion with microcysts seen in its base. So this is a case of mucinous cyst adenoma associated with pregnancy. Here, this is a large adnexal lesion, and this is the honeycomb appearance. And this is the picture. This is the ovarian cyst, and this is the honeycombing associated with mucinous cyst adenoma. Minimal vascularity. So when we have adnexal mass with pregnancy, it may be a diagnostic dilemma to us. Adnexal mass with pregnancy is usually benign. In 95 to 99% of cases, it is benign. Presence of corpus luteum cyst, persistent or not, functional cyst, mature teratoma, which is common also with pregnancy, endometrioma, serous cyst adenoma, mucinous cyst adenoma, para-ovarian cyst, and leiomyoma is very important entity also. But take care that we have 1 to 5% may be malignant. So malignancy also should be put into consideration in any adnexal mass with pregnancy. Maybe germ cell tumor, epithelial tumor, or sex cord stromal tumor, as we see in the case of lymphoma. And maybe primary or secondary. Borderline tumors is seen also in 1 to 2% of cases. It may be serous borderline tumor, or as in our first case, or mucinous borderline tumor. Cysts and more cysts. In most of cases, we found cysts with pregnancy. Either simple cyst, hemorrhagic cyst, theca-lutein cyst, or ovarian hyperstimulation. So this is a case with a large bilateral. There was the other ovary was the same. Bilateral multilocular or multicystic ovary. We can say that this is a multicystic ovary. Large multicystic ovary, it reaches up to 13 centimeters in length. What is the cause? In this case, the cause was, it is twin pregnancy. It was twins. So in twin pregnancy, we can see the ovarian hyperstimulation. Also, with the gestational trophoblastic disease, there may be thecal lutein cyst of hyperstimulation. Also, if the patient was under assisted reproduction and she take a lot of hormones, so it's vulnerable to be ovarian hyperstimulation in the pregnancy, especially in early pregnancy. So this is the thecal lutein cysts or ovarian hyperstimulation. This is another case. This is a small intrauterine pregnancy, but here in the adnexal region, there is a bilocular cyst, and this cyst shows the typical fishnet appearance of the hemorrhagic cyst, and also the other cysts show fluid level. So this is a hemorrhagic cyst, and usually it is subside throughout pregnancy. Another one. This is an intrauterine pregnancy. This is a gestational sac, but no fetal node yet detected. But in the adnexal region, we have a large echogenic non-vascular cystic lesion. Why it is cystic? Because there is no vascularity at all inside, and there is posterior enhancement. So this is an echogenic cystic lesion compatible with hemorrhagic cyst, and this hemorrhagic cyst may be hemorrhagic corpus luteum. So this is a hemorrhagic corpus luteum cyst associated with early pregnancy. Another case, it is early intrauterine pregnancy, 8 weeks, and there is something here in the adnexal region. This is the other ovary. And here it is a hyperechoic with shadowing. So this is a mature cystic teratoma. This is the dot dash sign. This is the dot dash sign seen with the mature cystic teratoma. Hyperechoic with tip of iceberg sign. So this is typical mature cystic teratoma associated with pregnancy. No problem. It can be, she can complete pregnancy, no problem. But the problem if there is torsion on top. This is another case. Multilocular cystic lesion with a solid part seen here, but we cannot inject because it's an early pregnancy. I think it's about 20 weeks. And here in the T1, there is fat component also seen inside. So this is a teratoma. But is it a mature cystic teratoma per se or not? We do second look ultrasound. A diffusion in this case will not give, will be not of no significance, because in the mature cystic teratoma there is restricted diffusion. But here on second look ultrasound, and this is the Doppler, we found that there is a solid vascular part within. So this is a malignant on top of mature cystic teratoma. We have also very rare entity, rarely encountered, I didn't see, the leutomas. The leutomas cause maternal viralization in 25 to 30% of cases, and they carry a 50% risk of viralizing a female fetus also. On sonography, unfortunately, it is very muscarding to the malignancy. It appears as heterogeneous solid masses, predominantly hypoechoic compared with the normal ovarian tissue, thickened wall, irregular internal contour, and enlarged ovary. They are often highly vascular and mimic ovarian neoplastic lesion. The clue to diagnosis that we found them in the third trimester of pregnancy, and we found that the female have viralizing symptoms, hirsutism, change of voice. So we can wait and see. Just it is a few weeks to wait until delivery, because after delivery usually they completely subside. So this is another rare entity we should put into consideration and correlate with other findings. We have also with pregnancy masses associated with pain, and this is also important. Sometimes pregnant female come with acute abdominal pain, and when we do ultrasound we found there is associated mass. What is the masses that are associated with pain? The first and the most important, the most common, is the leiomyoma. Why leiomyoma can cause pain? Either because of red degeneration or because of torsion. This is a pregnant female. This is a panoramic view. This is the placenta, and this is the normal fetus. Here the cervix, and here there is a fundal subserous myoma with the known claw sign. This is the uterine claw sign, and this is the fibroid with cystic degeneration seen. So this is a degenerated fibroid. Red degeneration in a fibroid. Also, there may be torsion if the fibroid is pedunculated, for example. Another causes of masses with pain, this is the fibroid showing degeneration with lack of vascularity. Only minimal peripheral vascularity with the bridging vessels coming from the myometrium is seen. Other causes of pain is ovarian torsion, and ovarian torsion is common also with pregnancy and may occur without any masses. The normal ovary may be torsed or an association with ovarian masses. And we have also the rare entity of the heterotropic pregnancy. So when you find intrauterine pregnancy and there is pain in one of the adnexal region, you have to go back to see if there is abnormality or not. Here is another case with large degenerated fundal fibroid. This is the uterus showing the fetus inside. This is the placenta, and here this is a large degenerated fibroid, cystic degeneration in a fibroid because it's not bright in T1. And here the operative, there is a pedunculated, large pedunculated subserous fibroid with degeneration, which caused epigastric pain in this lady, but she was about full term, I think 36 weeks. So we have a little talk on fibroids and pregnancy. Just as fibroids can affect pregnancy, pregnancy can affect fibroids. It is thought that fibroids grow during pregnancy because of higher level of estrogen. They increase in size in 15 to 20% of patients, and other patients did not enlarge in size. This is an early pregnancy with two very large anterior wall fibroids. Another effect of pregnancy on fibroids is sometimes called red degeneration. This is when a fibroid blood supply is cut off, causing it to turn red and die. It usually occurs in the middle weeks of pregnancy. Red degeneration can cause intense abdominal pain and contraction, which can lead to early labor and miscarriage. This is an early pregnancy. Here, this is a gestational sac with double decidual sign. But unfortunately, in the adnexal region, there is another adnexal lesion, echogenic lesion, highly vascular, ring of fire sign. There is a corpus lutein in that ovary, but this mass is seen juxta-ovarian. It is beside the ovary in the ampullary part of the tube, so this is a heterotropic pregnancy, one inside and one outside. So when this patient said that she has pain in the adnexal lesion, believe her, because she has another pregnancy here. So this is heterotropic pregnancy. Adnexal masses during pregnancy, the incidence due to large use of ultrasound has considerably increased during last years. We discovered them more. Large percent of ovarian masses found during pregnancy consist in simple cysts, which tended to disappear spontaneously during pregnancy. There are still a percentage of masses that persist in the second and third trimester that need to be monitored and sometimes surgically removed. If the mass increases in size, sometimes it is itself an indication to be delivered during cesarean section. Keeping in mind that adnexal masses diagnosed in pregnancy are generally benign, but you must consider that ovarian cancer still represents the second gynecological tumor for incidence after cervical carcinoma in pregnancy. Plus, although ovarian cyst torsion, hemorrhage, or rupture is uncommon in pregnancy. Some women may acquire emergency surgery for these complications while they are pregnant. Among histotypes that persist beyond the second half of pregnancy are the mature cystic teratoma is the common diagnosis, along with serous and mucinous cyst adenomas and endometriomas. Germ cell tumors, stromal tumors, and borderline tumors are almost the most common ovarian malignancy during pregnancy. Borderline ovarian tumors show more aggressive features during pregnancy compared to the non-pregnant women. Thank you, and I think it will help you when you find an adnexal mass during pregnancy.